Yeah, we are good to go.
Yeah.
Okay.
Good to go, sir.
Nishad.
Good to go, sir.
Okay. Thank you. So very good evening, everyone. My name is Dr. Abhishek Thakur, and on behalf of Emcure Pharmaceuticals, I welcome all of you. Emcure, it's a number one gynecology company in India, and it's a preferred partner in IVF segment. Materna being our core brand and epitome of quality and success, I, along with Mr. Nikhil Mehra, who is heading the marketing and sales for our division, are very, very thankful to Dr. Rajan Vaidya for giving us this opportunity to host this event and to be a partner for this wonderful academic initiative, and also thankful to Dr. Meenakshi Chaudhary to accept our invitation to join as a faculty. International Icons of IVF series has already scripted the success, as this academic marathon today is running into the 9th webinar of the series. So today the theme of the evening is male infertility from basics to advanced. Before proceeding further, I would request Mr. Nikhil Mehra, who is the head of the sales and marketing for our division, to please say a few words. Sir, over to you.
A very warm Monday, a very warm good evening to everyone who is watching from India and our viewers who are watching from other part of the world. Before I move forward, I would like to take this opportunity to thank Dr. Kevin for joining our today's meeting. Our beloved host, Dr. Rajan Vaidya, who has really supported us to take this event forward, and our beloved co-host, Dr. Meenakshi Chaudhary. So because of you, the world renowned faculties are joining this platform. And we are delighted to see that many viewers across the globe are here and watching live. So as rightly mentioned by Dr. Abhishek, so Emcure is the leading partner in the field of gynecologicals. We are number one in India in gynecologicals and top presence in more than 70 countries worldwide. We have world best products available with us. And we are keen to have more such academic feasts throughout our year, throughout 24/7. We are always available with different feasts across. So thank you so much. Now I am handing over to Dr. Meenakshi to take this event forward.
Thanks a lot, Nikhil. Good evening, good morning, good night later on, but good evening, good morning, or good afternoon, everyone, depending on where you are sitting and listening to this webinar. I would like to take this opportunity to welcome our invited speaker today, who in itself is a well-renowned figure internationally, Mr. Kevin McElhenney. Kevin is a trained urologist, consultant urologist in the northeast of England. However, his recognition is recognized throughout UK as well as worldwide. He set up the supra-regional andrology service at Centre for Life in Newcastle and treating male patients and partners and couples with severe male factor problems. He has also been the part of the British Fertility Society's executive committee for a number of years, and he's been the chair of the education and training, and currently he's the secretary of the British Fertility Society. He has also been involved with setting up several initiatives such as the mentorship program as well as STEM program for young school students of A levels, or in Indian standards, it will be the year 12 year students who want to make their career choices. He has also been very proactive in doing research in genetics of male infertility, psychosexual aspects of male infertility, as well as public awareness in relation to male fertility, which is a stigma or a less spoken topic. He has also set up a website to create information resource for men and women with fertility problems. So given all of his special interests, he is the best person to take us through the journey of men in relation to male infertility in a nutshell, from basics to advanced. Thank you so much, Kevin, for giving this talk. Dr. Rajan Vaidya, my co-host, will be taking the lead for the Q&A session at the end of this. So please do not hesitate to put in some questions at the end. Rajan, did you want to say any words before Kevin takes over?
No, I think you
Thank
have
you.
introduced Dr. Kevin so wonderfully well that we all are eager to listen about male infertility in a nutshell from him. And Kevin, the stage is yours. You can start your talk.
Okay. Can I share my screen?
Yes.
Looks like I've got it here.
Sure, sir.
Fabulous.
You're visible, right?
Okay, great. Have you got it all now? Thank you very much. Well, thank you very much, Meena, for your kind introduction. It's a great honor to be invited to speak to you today. I'd like to put out a warm namaste, particularly to the women who are watching this today. This is International Women in Science Day, and I'm cognizant of the fact that around the world, many women of Indian heritage are leaders in science and medicine as applied to the reproductive arena, and it is fantastic that you're here today. I'd also like to say to the men, today's Valentine's Day, and depending what time zone you're in, you may just have time to nip out to buy flowers or a card for a loved one in your life. Having heard about surgical sperm retrieval, though, at the end of this talk, you may be a little less inclined for romantic gestures. So to start with, these are my disclosures, including some of my non-commercial ones. I'd like to point out I'm BFS Secretary, but speaking today in a personal capacity. And some of the slides used, the images are by the kind permission of Mark Goldstein from New York City. So the learning objectives are to enable an understanding of how clinical assessment should be conducted in men, how male patients should be investigated, and we'll discuss what treatment options are available for male factor infertility. Why is this an important topic? Why do you need to know about it? Well, I think it's important because male factor causes are common. I mean, in many studies, they are the commonest single cause, and some of them are in fact treatable. Proper assessment can determine the best way forward, and it may permit a less invasive treatment. We would rather our patients could conceive naturally rather than require ICSI treatment, for example. More recently, work of Eisenberg and others has identified that there is a link between male factor infertility and certain chronic health problems in men, such as type 2 diabetes, hypertension, heart disease, and certain cancers. I think this is important because this has been illustrated as perhaps being the canary in the coal mine, the warning sign that all may not be well with men's health, because male fertility is indeed a marker of male general health. Another thing to bear in mind is that sadly, many of our couples will not become pregnant together. And I think this is a lifelong journey for them and a process. And if we can actually explain to them why they're in the situation that they're in to the best of our ability, we can give some of them some closure on this. And there is some science behind this, that this does benefit them in the longer term. So male patients are different. If a woman of reproductive age isn't pregnant but has no periods, she may assume there's a problem with her fertility, but men will have no such warning signs. So it can come as a tremendous shock to a man to be told that there is, for example, no sperm in his ejaculate. In general terms, men have a much poorer background knowledge of fertility issues than women do, and men may be more inclined to internalize anxiety, to store it up for the future. There's, as Meena has mentioned, there's a strong stigma in most areas around the world now, to varying degrees, regarding male fertility. Is still very much a taboo subject for many. Traditional masculine identity reports that being fertile is part of the way in which men perceive themselves as being a normal man, along with sexual potency, the ability to make decisions, etc. And if you unpick this, it can cause marked psychological damage to men and how they function. So we know that infertility is associated significantly with anxiety and depression. There is some evidence that if it's a male factor, the level of anxiety may be more marked for men. I mentioned internalization before. This means that men may be less inclined to seek help behavior, and in terms of that, they may be more inclined to not disclose their situation. They may wish to, in fact, avoid discussing it, or in fact, avoid their partners from seeking supportive help also. There is a link between sexual functioning and infertility. 25% of men have erectile dysfunction at presentation with infertility. Up to 40% can have a degree of erectile dysfunction at some point during their treatment. This could, in fact, be psychological as you might expect, performance anxiety, but also bear in mind that, like fertility, male sexual functioning, erectile dysfunction, is a marker of male general health. Therefore, it is not to be considered unlikely that the two can occur together. And clearly all this can have an impact on relationships, which can have long-term consequences. In terms of support, it never ceases to surprise me how many men who are deeply distressed with the situation wouldn't consider support from a counsellor or a psychologist. However, we need to look at this as some of these practices may be considered to be female-facing. For many men, they wouldn't entertain this form of support, but would certainly engage with other forms of support, particularly peer support, and anonymous online peer support is something that is perhaps developing at the moment. Another reason why it's important is there is perhaps better evidence now of a decline in semen quality. And this originally came from work that was carried out in Scandinavia, in Denmark, Finland, and other countries that appeared to show that over time, sperm quality was getting worse. Now, this was proved to be controversial, and many people have said that it really merely reflects the way in which semen analysis has been developed over the years. Every time there's a revision of methodology, there's a decline because the criteria become stricter. Having said that, a paper from a few years ago by an Israeli-led group appeared to show a 60% decline in sperm concentration only. Obviously, morphology and motility would be a little bit more subjective, but this was the strongest evidence so far that there was a real and significant decline over a generation or two, most markedly seen in Western countries in sperm quality. This is obviously a cause for concern. Not everybody supports this evidence, but it's the best evidence that we have so far to boot that there is in fact a problem. As to why it's happened, we don't know. There's been many changes in the way we live our lives over the last 40 years, and obesity is at epidemic proportions in the Western world and many countries also. There was a report out today showing that obesity in children in the UK is at record levels, which is obviously very sad indeed. So it could be something as simple as obesity. Other people have put forward the theory of testicular dysgenesis syndrome, and this attempts to link in the apparent decline in semen quality with the rise in the incidence of testicle cancer in many studies, the rise in abnormalities of male fetal development like hypospadias that are seen in some studies, and also perhaps the increasing incidence of low testosterone in older men, the so-called late onset hypogonadism, as all having a common etiology, and it's due to the process of masculinization of the male fetus being interfered with by chemicals that cross the placenta, such as pesticides, air pollutants, phytoestrogens, estrogens in drinking water, plastics with estrogenic properties that cross the placenta and cause these longer-term consequences. It's just a theory. Not everybody believes this, but it could have something in it. Even simple over-the-counter preparations like paracetamol and ibuprofen have been shown to have toxic properties to testicular development. So there could be a lot of things out there in modern life that are causing this particular observation. So when we carry out assessment, it's important because clues to the cause can be found by proper assessment, and recognition of a problem may allow for an intervention to improve semen quality and allow for less invasive treatment options. The less invasive the treatment option, the lower the potential risk to the pregnancy and to the child that's produced. And along the way, you may identify other medical problems that may need to be addressed, or at least the patient to be made aware of for the future. So when you assess the patients, this really applies, I guess, most to azoospermic men, you can put the patients then into a mechanistic category, and that then determines how you manage them. And this is quite a simple way of looking at it. You can characterize them into pre-testicular, testicular, and post-testicular problems. Now, the pre-testicular problems are those of the regulatory hormonal pathway. So we're talking here about problems of the hypothalamus, of the pituitary gland, tumors, trauma, surgery, radiotherapy that result in hormone deficiency. That means that the germ cells are not being appropriately stimulated. So it includes things like Kallmann syndrome, etc. If sperm is present, there will be no problem with delivery, and the hormones are doing what they're doing, but there's no actual decent level of them to initiate spermatogenesis. And of course, they're important because it can be managed with hormone replacement therapy. The commonest group, though, are testicular problems, sperm production problems, something wrong with the process of spermatogenesis in the testicles, ending up in the position that there's either no sperm or perhaps sperm of inadequate quality for the patient's partner to become pregnant naturally. In these cases, the hypothalamus and pituitary gland are working normally. FSH is high because it's supposed to be high, because the brain isn't receiving the signal that sperm is being made normally. If sperm were to be there, there's no problem with sperm delivery. It's just not being made. So the post-testicular problems are situations where sperm is present in the testicle, it's being made normally, but it can't get out due to a blockage in the male genital tract, such as following epididymitis or vasectomy or ejaculatory duct obstruction. Or alternatively, it could be due to a neurological issue affecting the process of emission and ejaculation. Erectile dysfunction itself, and I guess psychosexual problems, would also come into this category. When you take a history from the patient, obviously you need to know about their fertility history. Has either party been involved in pregnancies before? How long have they been trying for? What tests and investigations have already been carried out? In the man specifically, you need to ask directly, did they have a history of any significant testicular injuries, such as put in front of a doctor or a nurse, any operations of the testicles or groin, or any genital infections? We've mentioned already the link between male health and general medical health. So if they do have chronic health problems, this could be relevant and you need to inquire about them. Sometimes they need to be optimized by appropriate specialist input before embarking on the fertility journey. In terms of a surgical history, beyond genital and groin surgery, which obviously can affect the testicles, more widely, other operations can affect, or conditions can affect, sexual function in men, such as radical prostatectomy, pelvic surgery, where the pelvic nerves can get damaged, pelvic fractures, spinal cord injury, retroperitoneal surgery that can affect sympathetic nerve activity. So a slightly broader sweep can identify problems that may be pertinent. Certain medicines are well known to affect sperm function, but also bear in mind that over-the-counter preparations, or indeed traditional medicines, can have the same impact. Recreational drugs have some impact, at least there's evidence for some of them, and as indeed do steroids. The history of developmental delay may indicate an underlying endocrinopathy or genetic problem that may be responsible for the situation that the patient finds themselves in, and there could be a family history of genetic disorders. I've mentioned already about the importance of inquiring about a sexual history. You need to be quite direct. Any trouble with erections, any trouble with ejaculating. It's surprising how common these problems are. Some of them can be fixed fairly straightforwardly with counselling. Others may require different approaches, but they're important things to ask about. And finally, the patients like to ask about environmental and lifestyle factors. We'll talk a bit about that later on in the talk. The bits you probably don't want to hear is that I believe it's very important that the male patients are examined, and Dr. Chowdhury is aware of this. I think you can find out so much by examining the male patient. For starters, you can assess whether the testicular volume is normal or not. If they've got no sperm in the semen or poor quality sperm and low volume testes, you know it's a production type problem. It won't really be anything else. Now, the volume should be more than about 15 million per mil, it says. Sorry, more than 15 mils, up to about more than 19 mils, according to some other studies. If they're larger than that but smoother, it's not really a problem. If they're small, it indicates hypogonadism, and also if they're soft on palpation, they should feel firm but smooth. You need to be aware of the other aspects of the anatomy, the epididymis, the vas. Think about testes cancer, which is twice as common in infertile men, and all patients with production type problems should be advised about this and shown how to self-examine their testicles. If they do find lumps, an ultrasound scan is very reliable at diagnosing testicular tumours early, and it remains the most curable solid tumour. The epididymitis themselves should feel like sort of caps at the top of the testicles. If they're distended, it can suggest an obstruction. If they are scarred or irregular, it may mean that it could be as a consequence of previous infection or surgery. The vas deferens can sometimes be difficult to feel, particularly if you've got an anxious patient in a cool room who may be overweight, a thick-walled scrotum. So what we can really do to mitigate for that is to ensure that the patient is as relaxed as possible, that the environment in the room is warm. You feel the vas are located at the backs of the spermatic cords. If you can't feel them, then obviously it could suggest that the reason for the azoospermia could be congenital bilateral absence, and they could well be a cystic fibrosis carrier. In my experience, ultrasound scan is not so reliable for the vas deferens. The physical examination is really the best way to identify their presence or absence. So varicose seals occur in perhaps, according to some studies, up to 25 to 40% of men with attending the fertility clinics. They are graded by Hudson. A grade 3 varicose seal is one that you can see. A grade 2 is one that you can feel but not see. And a grade 1 is a varicose seal that can only be detected when the patient strains. And they are best detected when the patient stands up. So you have to stand up, clench abdominal muscles to accentuate the varicose seal, which should then diminish when they lie flat. As per the slide, they're far commoner, 6 times more common on the left side than the right for anatomical reasons. So in terms of investigations, according to the EAU guidelines that were revised last year, that's the European Association of Urology, obviously all men have semen analysis. I tend to perform hormone profiles and genetic investigations when it's below 5 million per mil. Some of the guidelines will say below 10 million per mil, but the pickup of an abnormality, unless they have any obvious physical sign, between 5 and 10 of a problem is low. So testosterone and FSH remain the bedrock of hormonal evaluation. If they were deficient, you would then go on and examine the rest of the axis. Estrogen can be used, I guess, in obese men to look at the estrogen to testosterone ratio. And prolactin, you would look to if you were wanted to exclude, say, prolactinoma, or there were other concerns about symptoms, visual field defects, sexual problems, etc. Radiological studies, I need an indication. I don't routinely scan everybody. As I said, I'm a big fan of examination, but obviously, if you did find a problem or a varicose seal, a scrotal ultrasound scan would be helpful. If you're looking at a diagnosis of ejaculatory duct obstruction, which is low volume ejaculate, aspermia, often pain at orgasm, this can be confirmed by transrectal ultrasound scan, or in fact more commonly nowadays, MRI, to identify dilatation of the ejaculatory ducts in the seminal vesicles. Vasography you would do in the context of vasal reconstruction if there was perhaps some concern about a more proximal blockage following, say, hernia repair, but that would be not so commonly done. So these are the 2010 reference ranges. I'm aware that they've been updated, but they aren't massively different. I believe there's no upper limit to normal range for volume, and concentration will be 16 million per mil rather than 15. So there are not really any massive changes there. The important thing in all this is that you need to ensure that the lab that you are working with has got good quality assurance measures in place, because you're completely dependent on their ability to deliver reliable results. And it's very important they are supported in this. Sperm DNA fragmentation is something that's emerged over the last, I suppose, 10 to 15 years. So in essence, DNA fragmentation in sperm is caused by free radicals that can be induced by lipid peroxidation. And this can happen as a consequence of a variety of things, including infection, systemic infection even, varicose seals, heating, smoking, obesity, general ill health, etc. So a broad range of things can cause this. And of course, sperm have little restorative machinery to repair such damage. The theory is that semen with a high percentage of sperm DNA fragmentation is associated with fertility problems such as fertilization failure and implantation failure. There are a few problems though with this, including the fact that the reference ranges are fairly broad between kits, so it's difficult to clearly define what is normal globally. Interventions such as putting the patients on antioxidants or treating a varicose seal can reduce sperm DNA fragmentation, but a problem with the kits is that the kits will obviously destroy the sperm to work out the level of DNA fragmentation, so you can't use the kits to pick out individual sperms with low levels of sperm DNA fragmentation. Having said that, a sperm that has good motility is likely to have better DNA fragmentation levels than a sperm with poor motility. So maybe our embryology colleagues are doing this already. A lot of the study data is not great, and there are no kind of proper randomized studies. It doesn't really fall part of any standard guidance currently. Obviously, that might change in the future. Anti-sperm antibodies are largely historical. Meta-analyses have shown that they have no impact on IVF or ICSI outcome, and they're not really routinely tested for nowadays. The HabSelect study that was performed in the UK a few years ago looked at the ability of sperm to bind to hyaluronin, which is something that is found on the surface of oocytes. They were using this as a physiological marker of function, in that sperm that could bind hyaluronin might be better quality sperm for ICSI treatment, but the study didn't show an advantage in favour of it, although I gather that the secondary analysis did show a reduction in miscarriage rates in older females. But overall, ICSI is not something that is widely used nowadays. The hormone profile, though, as I mentioned, remains very helpful. FSH and testosterone should be checked as close to 9 o'clock as possible. If those hormone levels are both low or absent, the patient's got hypogonadotrophic hypogonadism, a pretesticular mechanism. More commonly in the UK nowadays, what we would see is a patient who has absent or very low FSH levels. If checked, LH will be low also, yet testosterone is normal or even high. This patient is taking exogenous androgens. There's very little other thing it can be. Testosterone secreting tumours in men are extremely rare, never even come close to seeing one. But this you'd see regularly in clinic. It's a pretesticular problem. The outcome should be good if the patient reliably stops taking them. Some of these substances can contaminate protein supplements also, and it's a big problem in the Western world. I'm not sure whether it's in India it's a problem. It might well be. Young men with body image issues wanting to get fit in the gym. If FSH is high, it tells you that there's a sperm production problem because the brain isn't getting the signal back from the testicles that sperm's being made normally, which is inhibin B, and in that way regulating FSH release by an LH release by a negative feedback system. If FSH and testosterone are normal, then sperm production should be occurring, and if there's no sperm in the ejaculate, it could be an obstructive type problem. However, the caveat to this is that the trigger for inhibin B release is not the production of mature sperm. It's halfway down the pathway, meaning that if there's a complete block to production, late maturation arrest, after the point by which inhibin B is released, the brain is then fooled into thinking when sperm's being made, and it's not. In this situation, the patient can have normal sized testes, normal hormone profile, yet no sperm in the testicles at all. So if you're doing sperm retrievals on men who you don't really know why they've got their problem, you think it appears clinically obstructive, you need to warn them that sperm recovery is not guaranteed, and this can be the reason. It's also helpful to have histology at the same time as sperm retrieval to confirm that pattern if there's no sperm recovered for treatment. So the test that we do on men hasn't really changed much in many years. So karyotype is the kind of the bread and butter test that we would do. I tend to restrict this to men with a sperm concentration less than 5 million per mil. Between 5 and 10, there's a rate, but it's low. The closer you get to Ejaculatuspermia, the more likely they are to have a problem. If you go way above that, you're basically screening men who have a chance of conceiving naturally in any event. The commonest abnormality on karyotype by far and away would be Klinefelter syndrome, 10% of azoospermic men. The remainder, the other 2%, are men with translocations that can affect miscarriage rates in some situations, and also they can confer developmental abnormalities to children that are produced in that way, so they're worth knowing about. The long arm of the Y chromosome contains certain microdeletions or can contain those in the sperm-making gene areas. And if the patient has these, they may get sperm from the sperm retrieval for the commonest of these groups, AZFC. But if they have AZFA and AZFB, which confer a pattern on histology of Sertoli-Soloni syndrome and maturation rest, respectively, or any combination that includes A or B, apart from the odd case report showing sperm can be recovered, no one's ever really reliably done it. So those patients who have that should be counselled against sperm retrieval. This is why it's important to do Y microdeletion testing on all patients, particularly where you don't know what the etiology is before proceeding to surgical sperm retrieval. Otherwise, you're putting the patient at risk of complications of something that can yield them no benefit. Cystic fibrosis is a relatively common genetic disorder in Northern Europeans. 1 in 25 instances of carrying a gene. It's autosomal recessive. However, what's interesting about it is that even carriers of the condition can have an altered phenotype in terms of vasal absence. So if they have 2 affected copies, they can have the full syndrome with bronchiectasis, pancreatic insufficiency, etc., failure to thrive, which would obviously be picked up from birth. You can get milder variants because they're over 2,000 mutations available that can give some milder symptoms. So sometimes you might find a patient who's got absent vas deferens and a history of kind of atypical asthma, and it could be a cystic fibrosis variant. You would test for cystic fibrosis in our patients, in those who have a vasal abnormality on examination, a family history or partner history of cystic fibrosis. One final thing to mention is that the mutations can be racially specific. Men of Asian origin can have cystic fibrosis gene mutations, but they tend not to get mutations that affect the lungs and affect the pancreas in the same way in homozygous form that they do in the Northern Europeans. Yet they can still have problems with Wolffian duct development, as you can see in the patients who have got fertility issues and are cystic fibrosis gene mutation carriers. So overall assessment, you need a thorough history examination. High quality semen analysis remains, I think will remain, the bedrock of assessment. Other tests can be performed but may have an unclear role. A hormone profile, though, is extremely useful for patients with significant male factor issues, and genetic testing should always be performed where appropriate. Hopefully in the future, there'll be a better understanding of the genetics of male fertility, which is quite complicated. And then at that point, it'd be much easier to give a patient a clear diagnosis as to why they're in the situation that they find themselves. So patients obviously want to improve their semen quality, and what can we tell them about that? So there's obviously lots and lots of information out about this on the internet, and the patients will be aware of this, but what should you be telling them? Lifestyle optimization. The advantages of this of getting regular exercise, losing weight if you're overweight, a healthy diet, fruit and vegetables, it's cheap, and it may well have other health benefits, both physical and psychological for the patient, and potentially through the impact of these changes on epigenetics for any children they might have. The disadvantage is that the evidence for a lot of these things that we read about isn't consistent. Some studies show an advantage for a certain thing, other studies don't. The impact on an individual might be quite small, it's likely to be, and some interventions can be quite time consuming. For the individual things beyond that, there's lots of talked about. Again, the evidence can be inconsistent. I mean, most studies will show that cigarette smoking is harmful. They cause sperm DNA fragmentation, but in fact, not all studies have shown a problem with smoking, but most of them do. I think it's sensible to tell your patients to stop smoking. Alcohol doesn't appear to have a cause a problem unless it's heavy, prolonged consumption, but there's excellent evidence that steroids will cause harm and they need to be stopped. There's moderate evidence for recreational drugs like marijuana also. It's difficult to justify telling a patient to change their job, and the off chance it might improve their semen quality, but there is a link between certain sedentary occupations and those working in a heated environment and sperm quality. But there is good evidence for those working with pesticides, solvents, and heavy metals that can harm fertility. Hopefully nowadays, with the use of appropriate health and safety equipment, these changes should be mitigated. But I think some of the earliest studies looking at an impact of occupation on fertility did come from people looking at pesticides, etc. So that there is good evidence for that. I think there's reasonable evidence now that obesity is harmful, and the mechanisms by which it can affect fertility can include an impairment of the hypothalamo-pituitary gonadal axis by increased levels of circulating estrogen produced by the adipose tissue. Adipose tissue can also produce inflammatory mediators, adipokines, that can affect fertility by causing sperm DNA fragmentation, as can scrotal heating. Exercise, moderate exercise has got positive benefits and certainly stronger benefits on general health, but we don't see these so much in endurance sportsmen. So if there are regular marathon runners, you might recommend that they dial down a bit on their training until they've completed their family goals. But there is regular, reasonable evidence for scrotal heating that it's harmful. And again, this is through its impact on sperm DNA fragmentation. So a lot of our patients will be taking antioxidants and supplements already. What do we think about these? So the advantages are that it may improve semen quality and also sperm DNA fragmentation, because some proponents will say that there isn't necessarily a fantastic link between conventional semen quality and DNA fragmentation levels. And it may also therefore improve outcomes in natural conception and in ART. The disadvantages of this approach are that the cost is variable. Some products are expensive and we don't really know what the ideal composition and indeed duration of taking it is. Certainly some of these products can potentially be harmful if taken to excess. They can cause reductive stress. There's evidence, as demonstrated in the Cochrane review from a couple of years ago, of a 5% natural conception advantage in those taking them, but the evidence leading to 5% is not strong, so it clearly needs a bit more work on it. Varicose seals, I mentioned, are common in men. There's pretty good evidence that varicose seals are harmful to sperm quality. There's some evidence that treating varicose seals improves some sperm quality if it's poor, and it may improve spontaneous pregnancy rates and the outcomes for surgical sperm retrieval. Treating a varicose seal can normalize sperm quality and allow for less invasive ARTs. Disadvantages are that it requires medical intervention, the outcome on the individual is uncertain, and the impact on pregnancy rates isn't strong. It can also take a while to become maximally effective. So treating a varicose seal, particularly in a situation where the man's partner is older, it needs careful consideration. So overall, lifestyle changes. I think some interventions can have a small positive benefit on semen quality, but certainly a stronger one on physical and mental health. Antioxidants and supplements, there's evidence of a slight improvement in semen quality and conception rates, but the evidence is not strong. Varicose seals, treating varicose seals can have a positive impact on sperm quality. The evidence to say that varicose seals should all be treated isn't really there. And look at the guidance, the Americans' guidance, I think it's fairly pragmatic, which is that if they've got a clinical varicose seal, one that you can examine and find, they've got evidence of infertility and evidence of impaired semen quality, it's reasonable to treat it on that basis. But the evidence behind all this is uncertain. It needs a better study really to confirm it. And if there's persistently no sperm, what do you do? Well, through assessment, you may identify a correctable or manageable cause, such as chronic ill health problems. So you may identify they've got hypogonadotrophic hypogonadism and therefore can benefit from hormone replacement therapy, maybe taking steroids, maybe a problem with sexual function, etc. A less invasive intervention may be applicable, such as varicose seal treatment I put in there. That may restore sperm to the semen, allow ICSI, so the patient can then proceed with their partner for treatment. But if there's no sperm, or indeed ICSI suitable sperm, i.e. they've got, say, small numbers of non-moving sperm in the semen, think about surgical sperm retrieval. So in terms of surgical sperm retrieval, you first of all need to work out the mechanism. Is it obstructive or non-obstructive? And you do that in the way that we've outlined earlier in the talk. If they do have non-obstructive azoospermia, the chance of achieving biological paternity is not great. So it's important to at least raise the issue of other ways of family formation, including donor treatment, adoption, fostering, or choosing not to have children, as many couples increasingly do. If they have non-obstructive azoospermia, the evidence now really suggests that you should go straight for microtesting and avoid the kind of slow escalation of procedures with teaser, single-site testing, multi-site testing, etc. Just go straight for the operation that's believed to have the best benefit. You'll also hear about other indications for surgical sperm retrieval, such as Cryptozuspermia, where there's small numbers of poorly motile sperm present after post-prep spin down. Some people have advocated performing sperm retrieval in that context, or alternatively, performing sperm retrieval in the situation where the ejaculate sperm has high levels of sperm DNA fragmentation. But these approaches aren't proven and aren't really recommended yet. That may change in years to come, but isn't something really we would advocate with our patients. In obstructive azoospermia, the chance of finding sperm by any technique is high. It should be up near 100%. The method that you choose depends on what you're used to and what works for you. So you can do an aspiration type procedure like a PISA. You can see top left where the epidermis is immobilized between the finger and thumb of the non-dominant hand, and under a local anesthetic block, a butterfly needle is placed in and the fluid aspirated so that the scientist in theatre can tell you whether good numbers of moving sperm are present. And if so, you can stop. And if you find no sperm, then you can put a bit more anesthetic in and do a percutaneous biopsy. In teaser, you get sperm directly from the testicles itself. You tend to get a lower sperm yield in teaser than with PISA. Teaser's top right. In the middle there in black and white, you can see a MESA, which you can do under general anesthetic, where you deliver the testicle through a midline incision. You try and aspirate the sperm under an operating microscope from the epididymis, And if you don't find anything there, you can do multi-site testicular biopsies. There's some evidence that MESA gives more sperm than other procedures in this setting. Or you can do an open biopsy as bottom right. So the important thing is that you just have a system that works for you, and you get good sperm results. The evidence that one is better than the other in terms of fertility outcomes isn't really there. The non-obstructive azoospermia, microtesting is the procedure of choice. So some studies, Schlegel report success rates of up to 70%, which is indeed very high. Most studies suggest that microtesting recovers sperm sort of around 50% of the time, 40 to 50% of the time, with a lower volume of tissue being taken. So microtesting, for those that haven't seen one, is performed usually in a general anaesthetic via a raphe incision. The technique described by Schlegel involves making equatorial incisions in the tunica alpigina of the testes, spreading the parenchyma and examining the substance of the parenchyma under an operating microscope, looking for dilated tubules or tubules that look more normal amongst, often you can see in the picture there, lots of scarred and atretic tubules that will not be containing sperm. So you take out the good bits, the scientist looks for sperm, and if you find sperm, then that can be used for fertility treatment. This sperm can be quite difficult to store reliably because the quality of it often isn't great, and you're talking often about very small amounts of sperm. The studies say the complication rate is low, but if you look at what you're doing, it's not surprising that the patients can come back with hematomas, abscesses, etc. It does happen. So you need to have a good system in place for looking after these people. There's also a rate of hypogonadism or low testosterone in the longer term. The patients need to be warned of this too. So in conclusion, in a nutshell, male factor infertility is important and men should be properly assessed. There are a range of investigations available that can help to explain the problem, but some of the tests have got a weaker evidence base behind them. And if you're using these tests, you need to make sure the patients are aware of their value. Lifestyle and some interventions, they've got a modest role, I think, to play in improving sperm quality and indeed general health. Surgical sperm retrieval is established, and the procedure chosen depends on the underlying mechanism of fertility. Even if you can't work out a specific reason, you should be able to put them into a mechanistic category. But if they've got non-obstructive azoospermia, they should be warned at the outset that live birth rate at the start is going to be low, and that should be mentioned, and they should be made aware of it. So just to mention, finally, as Mina alluded to, this is the website we have. It's an informational site. It's a non-commercial site, although it's supported by Cryos. There's no money involved. It's just a way where patients can get information accurately written by world experts on a whole range of fertility topics. And it'd be great if you could share that with your patients. Thank you very much.
Thanks a lot, Kevin. That was a brilliant presentation. I will hand it over to Rajan for taking on the Q&A session. Thank you.
At the moment, it was a really fantastic talk. And at the moment, we are still waiting for the questions. But in the meantime, I can start off with one if, Kevin, you don't mind.
Of course.
When would you select a patient or counsel a patient for microscopic testicular sperm retrieval? And what exactly would you counsel the patient when you counsel them for microscopic testicular sperm retrieval?
So basically, if they come in for treatment of the man who's got non-obstructive azoospermia, high FSH, low volume testes, and that's what the reason is going to be, and then that would proceed at that point. So I tell them the operation takes 2 to 3 hours to perform. I do it with a general anaesthetic. I explain to them that it's done as a day case usually. They have antibiotics to start with. The risks include bleeding and infection, and there's a risk of shrinkage or loss of a testicle, and also a risk that their testosterone could be lowered in the longer term. Studies for that range between 1% and 5%. The more serious complications are rarer, but I tell them the testosterone will need to be checked. So I see them the following day, give them results and look at them. But as I say, that's the important thing, is they need to know that it isn't a procedure without risk.
Fine, thank you. That means you counsel them that you have a chance of getting sperm around 25%.
I counsel them a chance to get sperm around 40 to 50% most of the time. It depends on the case. So, for example, if they have something that's like Klinefelter syndrome, where you would imagine that the tubules will show Sertoli-Saloni syndrome, there's evidence that in that situation the chance of recovery is lower. It's about 30% compared to other histological patterns. So if they've got Klinefelter syndrome, particularly if they're older men, particularly if they've got low testosterone, in my hands, we find that they're a poorer group. So I would tell them that. I would tell them that.
Thank you very much. There is a question from our viewer. What is Necrozuspermia?
So Necrozuspermia is the finding that the sperm are dead in the sample. So, for example, you may have a sample that's got a load of non-moving sperm in it. The question is, are they dead or not? They might be obviously dead and degenerating, but you can do, for example, tests of hyperosmotic fluid, the reversible, to see whether the tails, move or not in response to the passage of fluid. Our scientists tell us that if the sperm tails are stiff and rigid, again, that's a marker of sperms that aren't functioning very well and are likely to be dead.
So
Kevin,
Kevin,
causes.
the listener wanted to ask, what will be the treatment strategy for necrozuspermia?
I was about to ask this.
Yes.
Oh, I see. Okay. Well, basically, if it's a persistent finding and you can find nothing in the patient's general health that you can adjust, for example, you might see someone that, like in a poorly controlled diabetic. That's why I've seen it before. Or they may have a genital tract infection that you can address and treat. If none of that works, all you're getting is kind of dead sperm in the ejaculate. I personally would think about surgical sperm retrieval at that point, because that might enable you to find something you can use for ICSI. So that is a situation. I think if you haven't got any useful sperm in the ejaculate for treatment, you can resort to surgical sperm retrieval, and it can work.
Okay, thank you.
Rajan, you wanted to take the next question?
I think you can go ahead. I can't.
All right. Okay, I can see them, so I'll ask. So one is quite related to the environmental factors. I think it's a very relevant question as well. Why is there a pandemic of oligoasthenospermia? So why are we seeing more and more increased male factor problems now?
Well, we're back to the start of the talk, whether you believe that it is declining or not, and why, if it is, why that might be the case. So certainly, if you speak to the kind of doyens, the world's expert in this field, a lot of them will think it's probably obesity. It's something to do with obesity, although it could also be due to environmental pollution. There's thousands and thousands of new chemicals are produced and released every year into the environment with fairly minimal investigation of their properties. These things will accumulate. We know they can affect other mammals because we find this in, for example, orcas and killer whales. We know that it can cause harm. So it's necessarily surprising it causes harm on us too, and they're around us. A combination of these things, I think, are likely to be responsible. So I personally believe it is declining.
Yes, indeed. So the other question was in relation to ejaculatory dysfunction, and what would be your recommended treatment option for men with ejaculatory problems?
Well, the first thing you need to find out is what the nature of the problem is. So if, for example, the patient reports they can't ejaculate. Have they got erectile dysfunction? Are they not ejaculating because they can't get an erection? You need to ask about that. If they can get an erection, are they reaching orgasm or not? Not reaching orgasm, I tend to do a simple kind of hormonal investigation. I check testosterone, prolactin, thyroid function. It doesn't normally show anything. This problem's usually psychosexual and can be addressed in that way. But if beyond that, there's no sperm in the semen and they're reaching orgasm, I would look to see whether the sperm in the post-orgasm urine. That's most common in diabetic men. If it is, it can sometimes be recovered and used for treatment. Sometimes I tend to use Sudafed, we can use imipramine, drugs to increase adrenergic tone in the genital sphincter to encourage antegrade ejaculation, because a small amount of antegrade ejaculation will have better quality sperm than a whole load of sperm that's been exposed to urine. In terms of other problems with reaching orgasm, in that situation, the best data comes from spinal cord injury patients. So they have an intact peripheral reflex that allows ejaculation to occur if the spinal cord injury is above, I think, L1. So in those sorts of patients, things like a penile vibrator, electroejaculation can be beneficial. But I don't even know if there may be one electroejaculation device in the UK now. They're kind of gone and people just do sperm retrieval on them. It's just quite straightforward. But you can get reasonable response in those patients with a penile vibrator. If this is my practice, you will commonly see those who've got a peripheral neuropathy or peripheral nerve problem from, say, pelvic fracture. Those sort of techniques, in my experience, don't tend to be so effective anyway. So a lot of them tend to end up needing sperm retrieval.
Okay, thank you. So another question is in relation to high-risk samples. So basically, what is the percentage of hepatitis B and HIV transmission rate in washed sample?
I
Swab
mean,
sample.
that's a tricky one for me to answer, really. My understanding is
Yeah.
it's very low. It's very low because the processing gets rid of it all.
Yeah.
I mean, I guess from my perspective, for surgical sperm retrieval, it's a difficult question because you get such poor quality sperm, it doesn't really survive the processing. So we're not really in a position to be able to treat those sorts of patients here and indeed anywhere else. There's no established protocols for that anywhere. I've asked ESHRA as well, and it's the same. But in general terms, though, I think washing is reasonably effective at getting rid of the viral particles.
Yeah, and just for the interest of the viewers and listeners, there is a good systematic review and meta-analysis. I think it was published in around 2016 in Fertility and Sterility Journal in looking at the transmission rate of HIV in wash sample from men who were HIV infected or seropositive for HIV with a discordant partner. And it showed 0% transmission rate. So it, as you rightly highlighted, is extremely, extremely low. And as regards hepatitis B, the recommendation nowadays by the national body in UK, the NICE, as well as the American Society of Reproductive Medicine, is that we shouldn't be offering sperm washing for hepatitis B men if the woman is immunized and vaccinated against Hep B. So that recommendation is there now, not to offer sperm washing in those cases. Thank you. If I've got the liberty, I would like to ask a question as well. Kevin, what do you think is the likelihood of aneuploidy risk or chromosomal anomalies in a pregnancy in men who have got high sperm DNA fragmentation? Probably there is lack of evidence, but I just thought I will ask an expert. Thank you.
Well, we don't know that, the answer to that. There's kind of roundabout evidence, I suppose. So if you look at data taken from studies looking at aging men, okay, so aging men are more likely to produce children with genetic abnormalities. And this is thought to be due, at least in part, to high levels of sperm DNA fragmentation in their sperm. But that's kind of an indirect approach for it. The main impact appears to be, if you believe the data, on reduced fertilization rates and implantation rate, higher miscarriage rates, perhaps. I'm not aware that the risk of aneuploidy in or genetic problems in children has been demonstrated. It remains a theoretical risk only, I think. But sure, there's evidence that miscarriage, perhaps in some situations, can have a male basis, possibly due to DNA fragmentation. But it's kind of a research question, I guess you could say at the moment.
Yes,
something allied to Meenakshi's question. So does it mean that men with higher DNA fragmentation index, would you offer them some medical treatment or lifestyle management and bring the DNA fragmentation index to acceptable limits of say 15% before you offer any assisted reproduction, or you wouldn't wait?
Well, that's a tough question. The international guidance doesn't support that. Nobody supports that. I guess the difficulty is if you've actually tested them, it's difficult then to ignore a test result, isn't it? I mean, I think you could argue that there is some evidence that a well-manned supplement, an antioxidant, does have some advantage. The evidence isn't strong, it's weak. You can justify it as that alone. The problem with the kits are some of the kits are very expensive for patients to be able to afford. And what is it telling you? If they've got a varicose seal, something correctable, again, maybe that's the reason. Maybe you might show that those people have high levels of sperm DNA fragmentation, but the proponents of the kits are suggesting it's used on all couples, really. They're suggesting quite a broad sweep. And I'm not sure necessarily what the advantage would be in those men.
Right.
Thank you very much.
Right. If I may ask two more questions, or maybe more than that, time permitting. So, Kevin, you know, with the surgical sperm retrieval like microtesting and all that procedures, do you think there is a role for pre-op treatment like anti-estrogen, HCG, anything like that to improve the sperm count or before we do a sperm retrieval procedure? Thank you.
Well, I tend not to, and this is what the guidance says. None of those should be done outside a research study. That's what the latest EU guidelines reiterates. I think the exception, I use clomiphene sometimes if the patient's hypogonad has low testosterone and is symptomatic from it, because it won't harm fertility. But certainly things like you have patients on HCG for years, and it's difficult to kind of figure out what is going on to start with. Did they have some hypoc? Has it been missed? It's difficult to really to figure it all out. So I prefer not to. You put patients on drugs off license, if they have a complication. As a doctor, you can be a little bit in trouble really if you use something beyond its license in an experimental setting. Sure, great to be involved in a study at it. For routine practice, I'm not sure. Giving people FSH, give them an FSH when FSH is already 20, 30, 40, what is it you're trying to achieve? FSH deficiency is not the problem in these men.
Yes.
It's the ability to make sperm that's the problem. So I think it's a slightly crude approach. I don't understand the science behind it. I tend not to use it routinely, no.
Okay, thank you. And what about the last question? What's next? We are going futuristic now. What's next in relation to innovation for future ART in relation to male fertility problems? So what do you think is the future next?
Well, I think there's a lot of interesting things out there. We'd like a better understanding of the precise role of sperm DNA fragmentation, varicose seal treatment, of antioxidants. These things haven't really been fully understood, or even indeed pre-treatment with drugs. We'd like to know that. Requires studies. In the future, I suspect there will be germ cells, that there will be in vitro germ cells developed, and maybe that might render all this kind of thing obsolete. But I guess realistically, as you know from your own work with mitochondrial, this can take many, many years to come to fruition. It's like to post a whole load of problems along the way. I'd also like to be able to reliably store small numbers of very poor quality sperm. It's difficult to do that, but being able to do that would give patients an enormous advantage. So I think the future is interesting. And I think also in terms of diagnostics, we're likely within the next 5 years, I think, to have a much better understanding of what's going on at a genetic level. And we could do a simple blood test that can, by whole genome sequencing, tell the patient exactly what's wrong. And that might indeed correlate potentially with the success of sperm retrieval, the success of reproductive outcome. So those sorts of things I think will be where the next kind of frontiers will lie.
Thank you so much, Kevin. I think it was a brilliant talk and session, very enlightening as well for us.
Absolutely.
And yes, thanks a lot. Rajan, you wanted to add some few words?
I thank Professor Kevin McKinley from the bottom of my heart for one of the most enlightening talk of our series, and which was very, very informative, practical, and had a lot of take-home messages hidden in it. So we would definitely be circulating the recorded part of it to our groups. For those people, though we have a lot of attendance here, there is one question still coming, if Nikhil and if the time permits. Meenakshi, can you see the question? I can.
Yeah, it talks about antibiotics for a person's semen sample. What antibiotic do you prefer?
I guess, well, I mean, you need to really culture the organism to see what's causing it. That would be the sensible advice. So I would culture the semen and sit and see what it is, and I would just go on that. In terms of penetrance, ciprofloxacin and doxycycline have better penetrance than, say, trimethoprim, but I'd really just go on the sensitivity in that situation. That's important.
Indeed. And also from our lab perspective, our andrology technicians and all inform us that not all of them would be pus or infections. So some will be increased white cells, but others would be sort of dead sperm in the ejaculate, which may mimic like that. So debris, kind of cell debris. Yeah. So when you culture that, you would know whether there is really an infection or not. You don't want to overtreat someone.
Exactly right.
Yes.
Yeah.
Thank you so much, Kevin, and thank you, everyone. I'll let Nikhil take over the stage, or Abhishek, one of you, who's going to conclude the session.
Thank you, ma'am. Thank you a lot. Thank you for your nice words. First of all, I want to thank the man who actually is responsible for everything, the man behind the show, Dr. Rajan Vaidya, sir. Sir, I just want to congratulate you, because this is, I think, the 9th webinar in the series. And, you know, the kind of logins we had today, this actually speaks that, you know, how this webinar series is being accepted and being seen by each and everyone out there. So, sir,
Thank you.
very, very congratulations on capitalizing this whole event and, just taking it forward. We are very, very blessed to be part of this, sir. And sir, second part, Dr. Kevin, the talk was wonderful, and more than talk, sir, the way you handled the queries towards the end and you answered each and every question with detail, that was really wonderful. And Meenakshi ma'am, all I want to say is that, the way you pitch in and the way you just moderate the session, sometimes I feel, you do the work of the speaker, you do the work of the hosting, you do the work of the co-hosting, and the moderation also. So there's nothing left.
Important.
There's nothing
very
left for
important
us.
asset of our team. Yeah, perfect.
Yes, ma'am. So
Thank you.
to have this, and it's been I think the second time I'm being a part of this, and it was really wonderful evening and very crisp, nice, and I think every talk which ends on time, and that's always a great talk. Anything you want to add, sir?
So on behalf of Kishore, Abhishek, myself, and entire Emcure team, first of all, we would like to thank Dr. Kevin for the wonderful talk today. Meenakshi ma'am, a great co-host, and of course Rajan sir, thanks a lot for giving us this opportunity, and to the delegates who have joined us today. So it's a wonderful academic feast, and with Rajan sir, Meenakshi ma'am, we promise you that we'll be having more such feasts. So thank you so much. Thanks for joining all of us. Thanks a lot.
Our pleasure, and
Pleasure.
see you.
From my
Thank you,
sense,
Kevin, once again.
Thank you
thank you,
very
sir.
much.
Thank you. Thank you, everybody. And wish you happy Valentine's Day. That was
Thank you, Kishore.
Bye-bye. Bye-bye.
Have a great evening.
Yeah, you have a great
Thank you.
evening.
Bye-bye.
Thank you.
Bye-bye. Thank you. Yeah, how did that go?
It was
It was
fantastic.
very fantastic.
By one of the-
Great.
one of
Thank
the
you, sir.
best
Thank you, ma'am.
webinars.
Yes.
Thank you,
yeah.
Rajan sir. Thank you, Meenakshi ma'am.
Most
Always
welcome.
pleasure to
Excellent
have.
discussion.
Yeah. How many logged in the end, like
We
for
will
the
get
live
a-
session?
Yeah, so we'll get a final update from the agency, post the event. So
Yes.
they share the numbers. So, but I think it is more than 500 for sure.
All right. Okay. So
Okay, great.
that's great. Yeah.
And this
very
time,
good.
as compared to all last time, this time questions were, quite.
Yeah, questions came because every time I have to think and ask questions. This time
Yeah.
there were practically questions. So I
These were
thought that was
wonderful
very good.
questions which were practically important to them.
Yes,
Yeah.
indeed. So like a practical questions related to the very pragmatic ones. So
And,
very good.
Wonderful.
a lot of
Meenakshi ma'am,
doctors.
love to see you again to India, ma'am. Please plan.
Yeah, I mean, what I was thinking is that
Yeah.
maybe the last webinar we could do sort of a live together with the speaker who could be this, but maybe we could get together with all the COVID restrictions off. Maybe
Yeah.
you can organize a seminar together or
Yes.
No, certainly.
meeting, yes,
We can plan
over
something.
there.
Yeah, physically.
Yes, yeah.
That's right.
Absolutely.
And I would love to
Right.
come to Pune. I've never been to Pune actually, surprisingly.
Oh,
No.
actually, I've been in Mumbai and never been to Pune is something which I can't imagine.
Yes,
Most
I know.
welcome, madam.
It's such a
So
shame that I've
probably
never
you
been to
are
Pune.
waiting for Emcure team to welcome you at Pune.
No,
That's
no,
the reason
I
why
know.
you are
I'm just
waiting,
waiting
sir.
for
We
you
are
to
waiting.
invite me.
Ma'am, just let us know when is your time. We'll, send a formal invite, everything, and we would love to host you over here.
Yes, yeah, fantastic. Thank you. Yeah.
Thanks a lot. Thank you so
All right.
much.
Thank you, everyone. Good
Okay,
so
evening.
much,
see you.
Good
madam.
night
Thank you.
now.
Thank you, Rajan sir.
Nikhil, Kishore
All right.
and Dr.
Thank you
Abhi.
so much, sir. Thank you so much.
Thank
madam.
you. Thank you,
Thank you.
everyone.
Looking forward for
Bye-bye.
the events.
Good night.
Bye.
Good night.
Good night. Bye, Rajan. Bye, everyone.
Bye, ma'am. Bye.
Bye, sir. Thank you.